Hello, everyone. Thank you for joining in. My name is Lovo Coligo from Community Health Awareness Network, and today we are having a conversation on prostate cancer and also bringing you some update about the COVID-19 vaccine in the city of Worcester. And I'm so happy that you all have chosen to join us and be a part of this event. And we appreciate your presence. So thank you again for being a part of this. So few housekeeping we're gonna go through. If you're here and you have your phone on, please turn it on mute, just so we show respect to our speakers and whoever will be on the floor at the time speaking, and to also have a smooth transition while we are going through this conversation. Few things I want to run through here before we start. I want to welcome you all again. Even though we tried doing the Facebook, we couldn't, but I want you all to know that we are recording this conversation. So just be mindful if you have any noise in the background, or if you're in an area that is noisy, just mute your phone. And we're going to have speakers, and at the end of our conversation, we'll have a question and answer. So again, my name is Lovo, and I have Dr. Maddie Castillo on. I also have Dr. Stern and Dr. Sokolov, who are going to be doing some presentation, and I know Dr. Faye is going to be doing the Q&A at the end. But before we go into our conversation, I just want to talk a little bit about CHIM, the organization whose idea is behind all of this while we're here. And CHIM is a nonprofit organization in Worcester. Basically, our goal here is to empower members of the immigrant community through education. And we believe that education is power. The more you know, the more you are able to make better decisions concerning your health. And that's our major goal. And we know that the more people know, there's going to be a reduction in ER visit, because people are going to go for their primary care visit. They're going to start believing in the healthcare system, and the community is going to be healthy, and that's what we want. So what we do, we advocate, we train individuals in the community, we provide community resources or help individuals in the community harness resources, that is partnering with other organizations such as AdMeTech that have the information we need concerning prostate cancer, or maybe the American Heart Association, or any organization that have resources that we can bring to our community. We also educate, and education is the reason why we are here today, just to educate members of the community on prostate cancer and also on COVID. We all know COVID is like the thing right now. We're still fighting it. So we want to keep updating members of the community on COVID and the COVID vaccine, which is like the main thing right now. So the goal for the organization, like I said before, is to promote primary care visit, also to reduce frequent ER visit, and to promote informed decision making, thereby creating trust in the healthcare system. But the goal for today is to promote prostate health. We're going to talk about prostate cancer, understanding the benefit of early screening or early detection for prostate cancer, cutting edge technologies that AdMeTech have developed. They're going to share that with us. Also, we have Dr. Castillo here, who is going to talk about the COVID-19 status in the community of which we live. So, and also what we can do now with the lifting of the mask and all that stuff. So before we go into that, my dear Rufina, who was once our intern and now a part of our family, has some icebreakers that she wanted to share with us, some activities that she wanted us to do before we go into that. So I'm going to turn it over to Rufina. And then Rufina is going to introduce Dr. Castillo, then we can take it up from there.
Hello, good evening, everybody. My name is Rufina Ketter, and as Ms. Coligo has said, I was once intern with Jan, and now I'm part of the family, so I'm excited. I'm happy to be here once more. Today, while trying to figure some things out to do, especially icebreakers, I have set up a quick PowerPoint with some trivia on prostate cancer, but also COVID-19. So we're going to pull that up, and you guys, please feel free to join. If you know some of the answers, that'll be great. If not, we are going to take our time and learn today. So just give me 1 second. Let me pull up this PowerPoint and we will get started. So this is Community Health Link, Community Health Awareness Network, Prostate Cancer and COVID-19 Trivia. So please feel free to raise your hand if you want, or you guys can just shout out the answers if you know it. Most of the questions is just true or false. And I got a lot of this information from the American Cancer Society and also Johns Hopkins, which are good and reliable sources to get information on both prostate cancer and COVID-19, especially during these times. We do want accurate information. So to get started, the first question is, men of any age can get prostate cancer. Is this true or false?
Mitch, do you want to address this question?
Yes, please. Yes.
I'll be glad to. So, any age, yeah. I mean, the answer is yes. Any men of any age can get it. Obviously, it's more common as men get older, especially in the 50s, 60s, and 70s. Autopsy studies on trauma patients in Detroit actually showed a lot of men in their 30s and 40s. Rare as you get younger, but the answer is yes.
Yes. Okay. So we want fly answers. We're going to get more into this and we're going to get the full explanation. But yes, just yes or no. But thank you so much for answering, being the first one as well. All right. The next question. Prostate cancer often causes men to have trouble passing urine. Is this true or false? And please, anybody chime in. Feel free.
Actually, by the time men have difficulties passing urine due to prostate cancer, not other diseases, but due to prostate cancer, it means that prostate cancer has grown and sufficiently to cause symptoms. That's why it is so important not to wait for symptoms such as difficulties urinating or blood in the urine or pain before you get screened for prostate cancer with blood test PSA. Screening is done in healthy men.
I was just going to say the exact same thing that Dr. Stern said. By the time there are symptoms, it usually means the cancer is pretty advanced. Prostate cancer early on has no symptoms, which is why it's so crucial for the PSA screening. I couldn't agree more with what Dr. Stern just said.
Awesome. Thank you so much. Next question. Prostate cancer always needs to be treated right away. Is this true or false?
Actually, it is false because it depends on what kind of prostate cancer there it is. We are sort of having this conversation among experts in prostate cancer. There is prostate cancer is like a lion. It's an immediate threat to life. And yes, there is prostate cancer more like a mouse. And it's not threatening to prostate cancer. It is not threatening to life. It may not even cause symptoms in a man's lifetime. So that's why it is very important to implement accurate diagnostic tools currently available to figure out what prostate cancer is a lion and what prostate cancer is a mouse.
I love those analogies.
Lion needs to be eliminated, and mouse something that we can live with.
Right. Awesome. Thank you so much. Next, there's nothing that can be done to lower your chances of getting prostate cancer. Is this true or is this false? And I don't know if we have some other just general members coming in. If anybody would like to take a crack at this. Anybody? We have the docs in here giving us great information, but is anybody else here to try? No.
Can you please repeat the question?
Yeah, the question is, there's nothing that can be done to lower your chances of getting prostate cancer. Is this true or is
Mitch, do you want to address this question?
Yeah, I'd be glad to. It's false. So there are lots of things one can do to help prevent the risk. Diet, nutrition come to mind as being the most common and practical. Heart healthy behaviors are tend to be very good for prostate cancer, hopefully prevention, or at least maybe not making it as severe. So diet, exercise, and there's some certain things in the diet one can always add, lycopenes, which are in cooked tomatoes, resveratrol, which is in red wine, soy products. But there are things you can do to help either decrease the risk or minimize the chance of having aggressive prostate cancer.
I would agree with Mitch, and I would say that whatever is considered heart healthy diet would be good for prevention of prostate cancer as well, with the exception of soy products. Soy products are really, if you look at, let's say, Japanese men, they have very low risk of prostate cancer, and it is widely speculated that may be related to the fact that they use so much soy in their diet.
Thank you guys for that answer. So what I'm going to do now, for the sake of time, I'm going to fast forward to the COVID questions, and then we can get started in introducing Dr. Castillo, and we can continue with the presentation. So just bear with me. Oh, COVID question just came. So this is a COVID question. It says, you can only get the COVID vaccine if you are age 15 and up. Is this true or is this false? And anybody who's able to answer this. You can only get the COVID vaccine if you are age 15 and up. Is this true or false?
Dr. Castillo is just 2
5 to 11. Any from 5 up, you can get the vaccine. So we need to encourage to the younger ages to get the vaccines. Those are actually our lowest vaccination rates are from 5 years old and up. And we are working, the scientists are working on getting the vaccine for 6 months and up. That has not come to fruition yet, but hopefully it will come within the next couple months.
Awesome. Thank you so much, Dr. Castillo. Next question. Once you're fully vaccinated, you may not be required to wear a mask in public places. Is this true or false? I know things are changing now, but what's going on here?
More specifically now, since a lot of the mask mandates have come down, certainly if you have if your immune system is compromised, if you have medical issues, I think you want to be able to wear the mask. Certainly, if you're not vaccinated, you've got to wear the mask, and that's where we're standing right now. And certainly, if our vaccination rates are low, you want to be able to wear the mask also, because you want to be able to protect those that aren't vaccinated, those that are immunocompromised. But most recently, most of the masks have come off in indoor places and outdoor places, except for hospitals and trains and things like that you will, and airplanes that we're still looking at. But I would always say that you have to use that with caution. And again, if you have medical issues, I would certainly wear the mask. And still be careful, because we don't know what's around the corner.
Right. Thank you so much again, Dr. Castillo. So these are some of the references. As I said, we've got a lot of this information from the American Cancer Association and also Johns Hopkins. So you guys can feel free. I can also share this to anybody who's interested. But those are just some of the few questions that we have. So now, we are going to move into introducing Dr. Castillo, and we will be moving forward with her presentation. So, Dr. Maddie Castillo, Commissioner of Health and Human Services for the City of Worcester. Maddie Castillo, MD, has always held a professional and personal mission to work with underserved. She was born in Camagüey, Cuba, and immigrated to the United States in 1962 as a part of Operation Peter Pan. Raised and educated in California, she completed her medical training at the University of California, San Francisco. She moved to Worcester 32 years ago and has practiced as a board-certified physician in internal medicine in the Worcester community for both Family Health Center and UMass Memorial. She is also an associate professor of internal medicine, family medicine, and psychiatry at UMass Medical. In 2009, Dr. Castillo founded the Latin American Health Alliance. a nonprofit organization in Worcester, and dedicated to combating homelessness and drug addiction. And at present, she continues to serve as its medical director. LAHS program consists of the Hector Reyes House, a substance abuse treatment facility for Latinx males, and 2 transitional houses. In 2015, LAHS opened Cafe Reyes on Shrewsbury Street, an innovative job training program for the residents at Hector Reyes House and transitional houses. In September of 2015, Dr. Castillo was appointed as the City of Worcester's Commissioner for Health and Human Services, where she oversees the Division of Public Health, Youth Services, Human Rights and Disabilities, Veteran Affairs and Elderly Affairs, and Homelessness, along with advancing important new initiatives that fall under the scope of youth violence and the current opioid crisis. Most recently, she has been awarded in 2019-2020 the UMass Medical School Chancellor's Medal for Distinguished Service, the Edward M. Kennedy Community Health Award, Family Health Center Healthy Communities Award, and LIFT Community Hero Award, and WBJ Hall of Fame. So, without further ado, I would like to welcome Dr. Maddie Castillo.
So I want to at least talk to you a little bit about how we came about the vaccines and where we are now. I actually had the opportunity today to go and do some vaccinations. We actually parked our mobile van in front of well, I forgot the name of the market on Lincoln Street, but we parked there. And I was still amazed about how many people have not gotten their vaccines and how many people still were hesitant. And most importantly, how many people still, even those who had gotten their first and second dose of vaccines, who hadn't gotten their booster. And we're going to continue doing this until we figure it out. We have a good percentage of our community vaccinated. If we're looking at the new data, the new census data, which is 206,570 people, or we use the 2019 data, it all depends. We're close to about 68% of our community vaccinated. Those at least those that are eligible from 5 on that are vaccinated. But people always talk about, and still people mention, I don't trust the vaccine. And, people always will say, but you've gotten 1 million vaccines. Why don't you trust this? And, it was just recently made. I think it's interesting to note that they were made they started talking about this vaccine in 1960, and they were working on this mRNA platform, both for the Pfizer vaccine and for the Moderna vaccine. And so you can see that it's gone all the way through till now, that they have been really working on this vaccination until they improved it and got to where we are today. So next slide. Next slide, Lam. There we go. And it's just interesting to look at how this mRNA was made, all the different changes that they made to have this vaccine not have side effects, how they made this vaccine enter to your cells, and when it does, how it actually it disintegrates the particles that it made. So people say, does it change your DNA? It doesn't change your DNA, because as quickly as it goes in, it is a copy, a messenger of it, but it quickly, all the proteins from the mRNA disintegrate from the cell, and they use lipids to bring it into the cells. So a good technology that has been working since, have been planning this process since the 60s. So next slide. And then just to understand a little bit more, we had the Delta virus that came, and certainly that caused a lot of deaths and hospitalizations. And from the original virus that we had back in 2020, it had mutations, and it changed to the Delta virus. And you can see some of the mutations, which parts of the DNA changed for the virus, and some certain pieces came in and inserted itself in the virus. And then you see Omicron, which was the last virus that we had, which we had the big surge around December. you can see that there's many more mutations and many more deletions that were part of the virus. So next slide. So how do we even detect this virus? What are we looking for? People had all kinds of questions, whether, the tests that we do at home, what are those tests? Are they different than what we call the PCR test, which we call the PCR sort of the gold standard of the tests that we do? And you can see that where it says exposure, and then when we can actually detect the test. And so you see that when the PCR and what we call the antigen test, when we can detect it. And you can see that it starts around the 4th to 5th day, really, that we could actually detect the test. And so that's why people will tell you, wait to get a PCR test on the 4th, 5th day, because you can see through that graph that has the colored gold in it, that's really when you're having symptoms. And it's also when you're truly that you're infectious, but also that when you're going to be able to detect the test. And one of the things with the PCR test is that actually you can be positive for weeks on end after you're done with COVID, for an average of about 17 days, with a maximum of 83 days that you could still be positive, because there are still particles of the virus that are there. So next slide. So maybe I'm going to minimize this. So this is, we were talking about the virus, the Delta virus versus the Omicron virus. And can you just press the next slide down and you're, let me see if that, yeah. So what this is showing really is how much stronger, in the sense you can say, that the Delta virus was compared to the Omicron virus. So when we look at emergency room visits, we can see that Omicron had 2/3 the relative risk of sending children to the emergency room. When we look at hospitalizations and ICU admissions, we can see that it was 1/3 of the risk of having both hospitalization and ICU admissions, comparing the Omicron to the Delta virus. And the same with mechanical ventilation, that it was also 1/3 the risk of mechanical ventilation. So we know that Omicron was much more transmissible, but it didn't have the same effects as the Delta did with emergency room visits, hospitalization, and ICU admissions. So next slide. And so interesting about how they named all the viruses. The coronavirus started with the Alpha. That was the first one that we had. And we went through Beta, Gamma, Delta, Epsilon. And if you can press the next slide, Nu was the next one. And we didn't use Nu because it was a new virus sheet. We didn't use because of the leader of China. And so you can go back. And it can continue on. We're in Omicron, and we'll see what the next virus is. And like I said before, we don't know. Hopefully what we're looking to happen is that it becomes what we call endemic, that is part of the of all the other viruses that exist in our atmosphere, and that we learn to live with it. And so hopefully those numbers will stay low, but we certainly have to keep an eye on it. And our goals are really, as part of Health and Human Services, all the health departments, is certainly to continue looking at the different measures that we have to see if the virus is, if any type of the coronavirus is present. So we'll keep track of that and be able to make sure that if something is coming up, we're going to find out. So next slide. So the question is always, what mask do we wear? What mask don't we wear? And right now, with the Omicron, because it was so much more transmissible, we said to wear the N95. And this graph shows that if somebody is infected and wearing, for example, wearing nothing, the chances are that you're going to be getting the virus. If you're wearing the N95, for example, and somebody is positive, you can, depending on how long you've been exposed and what mask you're wearing, you can be, if you're wearing nothing, it will be 2.5 hours. But ultimately, if you're exposed to somebody and you're wearing an N95, it'll protect you for up to 25 hours. And those are just the N95s that we're giving out to everybody. If they actually have the N95s that are fitted in the hospital, that can increase. Actually, it says there are 2,500 hours of protection wearing those that are fitted. But the ones that we are passing out are the N95s or the KN95s. If you're wearing those and you're exposed to somebody, it takes up to 25 hours before that is transmissible. So next slide. So everybody says, why do I need a third shot? Why is it important for me to get a third shot? And you can see that initially when we had the vaccinations, we started with the vaccinations, that 2 shots brought you up to 90% effectivity of the vaccine. With both the mRNA and the Pfizer, it was lower when we were talking about the Johnson & Johnson, or in other countries they use the AstraZeneca. But then once you get boosted, and that they said it was 6 months that you needed a booster, we're now saying it's actually 5 months that you need a booster, because we see those antibody levels decline. Once you get boosted, it brings you back up to where you were. And this is, I think, one of the failures that we have, is that people are, we're not getting the message across to people about getting the booster vaccine and the importance of getting the booster vaccine. And right now, our levels of those people who are vaccinated and eligible for the booster, which is everybody who is 12 and up, right now is 54%. And so we need to continue getting those booster vaccinations for people. Next slide. I like showing this because I think it's interesting that this is we look at sewer water to find out how much COVID is in our environment, in our vicinity, looking at really at Worcester and the surrounding towns. And you could see when we first started with the Omicron virus, and you can see the numbers, and you can see when it shot up in December, started going up, and it peaked in January. We were having 12 million, virus concentration per liter. And then most recently, so that was January 2nd. That was when it was taken, and you can see in February 16th, you can see the graph markedly dropped to where we are right now. That was February 16th that this graph was done. And you can see that the numbers went from 12 million to 103,000. So markedly dropped of the virus. So the Omicron came quickly, and it has decreased quickly. And this is what we follow. This is what we'll continue to follow, to see if there is any other viruses in our community. So next slide. And I just I always want to make sure I mention that there's always inequities that exist in our healthcare system and in life overall, and truly affects our Latino community and our Black community. And one of the things we look at is a social vulnerability index, and where is it mostly affecting? If you look at the pink graph, you can see that the dark colors are actually where COVID hit us the most. And those are the same areas reflected in both the Latino community and the Black community. And we know that they are essential workers. They're the ones who live in multi-unit housing. And so when we're looking at social vulnerability, we look at socioeconomic. So if you can push the next slide and go. So when we're looking at social economic, we're looking at people who are below poverty, unemployed, and they may not have a high school diploma. If we're looking at household composition and disability, you can push the next slide. And again, people who are 65 years old or older, 17 or younger, or they're older than 5 but have a disability or a single parent household. And if you look at the graph and look at the first one that I showed you, or look at the Latino and the Black community, this is again where these vulnerabilities lie. And it's in those darker areas that you can see the household composition. And again, when you look at the next slide, the purple one, you'll see that the darker colors, it lies again, people who may not speak the language. And you can press the slide, the next slide. So minority status and speaks English, that may not be their first language. And then the next one, again, housing and transportation. You can press the line again. It all revolves on the same areas. So again, people who live in crowded buildings or multi-unit structures. And again, those are, again, it exemplifies the same neighborhoods that are our communities of color. And this is where we talk about the inequities that exist. And it is across the board, not only in health, but overall. Our highest areas, and these are highest areas in our country of social vulnerability, are Bell Hill and Great Brook Valley, and you can see the rest going down the slide with Pleasant Street and Chandler, University Park, and so on. So next slide. And I wanted just to make sure I mentioned that in those particular areas, we had the highest positivity, COVID positivity, and we have the lowest vaccination rates. This is looking at Mass DPH's data, and again, this is 2019 census for eligible population, that's 5 and above. And we're looking at first dose of people who've gotten the vaccine. We're at 83.2% getting their first dose. You know, we're up to 3 doses now. Those who are fully vaccinated, that's 2 doses, is 70.2% right now using the 2019 data. If we use the census data of 2020, which certainly our population went from 185 to 206,000, that number will decrease. And that's why we estimate it's around 65%, 68% that we have in our community fully vaccinated. When we talked about how many people we wanted fully vaccinated, what we called herd immunity, we were certainly talking much higher than that. We were talking really 75, 80, at least minimum of that to have herd immunity, which means that we may have people who are unvaccinated, but we have more people who are vaccinated, who protects the other people in the community, but also gives no place for the virus to go. One of the reasons that we have different mutations of the virus is because the virus still can infect other people who are not vaccinated, and it continues to change as we do that. If we were all fully vaccinated, the virus has no place to mutate. So next slide. And this is just, again, just looking at the 2 sides, I guess you can call that orange. If you can see where all the dots lie again, these are all the positive COVID tests that we have seen in our community. The ones that are packed in together are, again, the beautiful communities of our Latino and our Black community. And then again, looking at where we're vaccinated, which is the blue. The darker blue is the more vaccinated people are in the community, and the lighter blue is those who are less. And you can see the neighborhoods who have the least vaccinations there. And so when we look at the 2020 population data, and again, those are now, if you look at the first dose, is 73%. These are these are non-eligible, and 61% is fully vaccinated. And then when we look at that for the eligible population, again, for those from 5 and up, that we talked about now for the for Worcester, this is as of 2/25. We have 83% who received 1 dose, and again, fully vaccinated 70.2. So there's that discrepancy between the two, and so we average about probably 65 or a little bit higher that in Worcester that are vaccinated. So next slide. When we break down this data, looking at the different communities, if we look at our Latino community, We have 56% of the Latino community vaccinated compared to the state that has 69% of the community. So again, we're lower than the state there. We have improved dramatically, so I have to say this is good for us. In the Black community, 57.8 have been vaccinated compared to 68.3. And you see less of a discrepancy in some ways, 71% in the white community compared to 75.6 overall in the state. And again, for American Indian and Alaskan, we have a small population, but still we are less at 38 in Worcester, 38.8 and 45.5 in Massachusetts. So we're getting there slowly but surely, but certainly we need more vaccinations. So next slide. So again, looking at 2019 data, looking at those who are eligible, 5 and up. Here's the percentage of people as of February 22nd who have been vaccinated. And I've been talking about that age group of 5 to 12 that actually has gotten the least vaccinations. 25.4% of those who are 5 through 12 have been vaccinated in Worcester compared to 44.8 in Massachusetts overall, the state overall. But those numbers are still low for both Worcester and Massachusetts, so more of an emphasis has to be placed. And those coming up in ages 12 through 15, 58.9 have been vaccinated. The state's much higher at 74. 16 through 19, we're getting 50% vaccinated, 50.7, and the state it's at 69.9. So you can see that the numbers are the lowest for us are actually the ages of 5 through 29. We're doing fine at the ages of 30 through 75 plus. We're doing well. So our concentration has to be there. And again, also our concentration has to be in the Latino and the Black community where those numbers are down. So next slide. And we have a mobile van that we go out into the community to vaccinate. We also have sites that are stationary. We have the senior center on Fridays, 11 to 8 p.m. that we have vaccination clinics there. We have the Worcester Public Library that's open both on Wednesday and Saturdays, 11 to 7, no appointments needed. And Mondays is the YMCA on Main Street. And again, that's 11 to 8, and it's open every day, every one of those days. No appointments are needed, and you can go and get your vaccine there from anybody from 5 and up, including the booster vaccines. So this group has gone between July 19th of 2021 through February 17 through the city with our what we call the equity vaccine, which is really the vaccine that the state gave us to go out into communities of color and start vaccinating, because we knew the numbers were low. We knew that they had the highest positivity rates, or the goal was really to protect the community and be able to bring vaccinations to where people are. And so total, we've given 34,673 vaccines were administered to 16,317 individuals. And we went to about 490 community sites to be able to do that. And we continue to do that every single day. So next slide, I think that's the end. So if you have any questions, or we're saving them to the end, let me know, Lobo.
Thank you, Dr. Castillo. We're going to save it to the end because we're way into our time. We're a little late because of the technical. So, Sokolov, do I have to make you?
I'm sorry. I mean, are you ready for me?
Yes.
Oh, okay, cool. Then I will go ahead and start. Let me see if I can get my slides up here. And we will do that. So thanks as always, Lovo, for asking me to partake. So anyway, thank you. I'm going to give a 15-20 minute overview a little bit on both prostate health and prostate cancer. I'm the department chair at the University of UMass Chan Medical School, University of Massachusetts. I head up the urology department, and we have a very active prostate cancer program. Let's start a little bit on the prostate itself. A lot of people don't really know what the prostate is, and I don't want to spend too much time, but it's a gland. It's normally about the size of a golf ball or a little bit larger, sits just below the bladder in men, and its function is to produce semen, which is needed for reproduction. But as men age, older men, actually men of many ages, can get infections, inflammation. But as we age, both enlargement and cancer become issues that can cause men some difficulty with urination from the enlargement. Cancer we'll talk about in greater detail. So infection, inflammation, as the prostate gets bigger, as urine maybe doesn't empty as well, men can get infections. Usually pretty easy to treat with antibiotics. Symptoms are usually very simple, burning with urination, maybe some frequency, and it tends to be very easily treated with antibiotics. Enlargement, when I was training, the slides on the right down there on the bottom show a procedure called a TURP, where you actually go through and you clean out prostate tissue. When I was a resident or a medical student in the late 80s and resident in the late 80s and 90s, that was the most common way of treating enlarged prostates. Now we have multiple medications which work well. And again, if a man is noticing symptoms of not voiding well, waking up at night, feeling like they're not emptying, very common as men get older, the prostate gets bigger, and we can treat it in lots of different ways. Now, as Dr. Stern and I said earlier, those kinds of symptoms, the enlargement issues, the infection issues, changes in urination are very common in these benign conditions. They're very rare in prostate cancer. In fact, prostate cancer early on has no symptoms. That's why screening is so important, as we'll talk about in the next few minutes. First, just some numbers. It's a very common cancer. There are 250,000 new cases in the United States. About 35,000 men will die of prostate cancer each year. And as you'll keep hearing over and over again by Chan and by AdMeTech and Dr. Stern and myself, early diagnosis is the key to successful outcomes. You want to know what's going on as early as possible. And then we have a variety of treatments, depending on how aggressive the cancer is, how much cancer there is, what a patient's needs are, and what their expectations are. This is the most recent data for 2022 from the American Cancer Society. And again, you can see prostate cancer is being the most common cancer in men at about 270,000 cases. Very consistent actually with breast cancer in women, by the way. And death rate of 34,000, just behind lung cancer, but still a very, very common cancer, one that really needs attention, warrants attention, and as you'll see, is very common in the African American community. So what are risk factors for prostate cancer? Well, getting older. At any age, as we found in our trivia, people can have prostate cancer, but usually think of people in their 50s and 60s and above as having the highest risk. Family history, brother, father, grandfather, specifically, those can have a 2 to 3-fold increased risk. Cousins, uncles, and it can be both on the mom side and the dad side. Prostate cancer risk, if your maternal grandfather has prostate cancer, it increases your risk just as much as if your paternal grandfather had prostate cancer. In terms of ethnicity and race, African American men and men of African descent is really what I should have said. Men of African descent or African ethnicity have the highest rates of anywhere in the world. It is extremely prevalent in Africa, Afro-Caribbean communities, African American communities, and it's a focus of why we want this outreach, to make sure men are aware of this, their families are aware of this, and they get screened. There are some genes that are involved, some that can be inherited, some that can be non-inherited. As we mentioned during the trivia area, lifestyle is important, heart-healthy diet, exercise can all be possibly preventive, and also maybe can mitigate the cancer so it's not as aggressive or doesn't grow as quickly. And then there are environmental agents for the veterans in the group. Agent Orange is associated with prostate cancer. Smoking has an association. So a healthier lifestyle can help. Obviously, genetics and ethnicity do play a role in this, as does just the aging process. Now, Worcester County is really ground zero within the state for prostate cancer. The data on the second part of the slide is a little bit older, but what you see here is Worcester County. And down below, the incidence in Black men versus white men in the county. There's a almost 2.5-fold increased risk for a black man in Worcester County to have prostate cancer than a white man. And in terms of dying from it, there's also about a 2.5-fold increased risk of dying from prostate cancer as a black man as compared to a white man. So that hits home more than anything just how lethal and prevalent this cancer is, especially in the African ethnic communities. Same graph up here on the top. Obviously, I don't want people to be able to read this, but there were some missteps that have taken place. About 10 years ago, the United States Preventive Task Force decided that prostate cancer screening really wasn't indicated. And that's the second graph down here. This is actually our own data from our own institution. And what it showed was this precipitous drop in screening. And in the red circle there was the African American community in our region, and just a total drop in screening. And the data on the right sort of shows how much some of the family practice providers bought into this. And there was, for about 4 or 5 years, a decrease in screening, decrease in diagnosis, and very rapidly the number of men with more advanced cancers that already metastasized, went up. Fortunately, all of that has been reversed, and screening is now supported by the same group. But it was a fairly bleak few years, and for a man of African ethnicity, it hit them harder than most other populations. What's unique about the black men for prostate cancer? Well, it tends to be diagnosed later in the course of the disease, whether this is a socioeconomic issue or this is related to access, unsure, but later in the course usually means it's less likely to be cured and treated. Incidence of prostate cancer, depending on the community, can be anywhere from 2 to 5 times higher in the black community. Black men are at risk for more aggressive disease. At baseline, there's a higher prostate-specific antigen blood test. That's our screening test, and testosterone, which sometimes makes it confusing for practitioners who don't deal with prostate cancer regularly to interpret results. Within the prostate itself, there's a higher incidence in the part of the prostate, which is sometimes more difficult to diagnose. And African American men also have a lower rate of definitive treatment, whether this is due to distrust of the health system or it's due to access and education. It just happens that definitive treatments, the surgeries, the radiation tend to be utilized less in this community. What is screening? Well, you've heard Dr. Stern and me several times speak about PSA. That's prostate-specific antigen. It's a protein that's made by the prostate. Some gets into the bloodstream, and since the early 1980s, we've used it as a screening test for prostate cancer. Increased levels of PSA are associated with an increased risk of prostate cancer. Combined with that PSA blood test is an annual rectal exam, feeling the prostate. Prostates tend to normally feel like a rubber ball. If cancer has been there and is developing, it can be hard, and sometimes very aggressive cancers don't produce much PSA, so a digital rectal exam is an important way of diagnosing it. So all men of African descent, especially once you reach the age of 40 or 45, men who have a family history, the ages of 40 to 45, men who aren't Black and don't have a family history, maybe 50 or 55, but starting that annual screening with a primary care physician at those early ages is crucial. And as we know, cancer can develop at any age group, just more commonly as one gets older. If either of these is particularly abnormal, we move to the right side of the screen. That's the latest in biopsying technologies. We have it at UMass, what's called MR fusion biopsy, where you combine both an MRI of the prostate and the traditional ultrasound biopsies. It's much more accurate. I can tell you we've been doing this now for 6 years, 5 years, done several thousand in that time, and our detection rate has doubled, went from 33% to 70% with the addition of just this technology. This technology, Dr. Stern might relate to this later on, but a lot of the work of AdMeTech is actually using radiologic studies, not only to better diagnose more aggressive cancers, but also maybe one day to focally treat them, where you can treat just portions of the prostate as compared to the entire prostate. And a lot of this is based on this early biopsy platform of using MRI and ultrasound. So let's assume that biopsy comes back. We want to personalize and individualize our treatment. We want to make sure the right patient gets the right treatment. We don't want to overtreat less aggressive cancers. We don't want to undertreat more aggressive. So we divide men first into three categories, whether it's localized, meaning contained to the prostate, locally advanced, meaning that it's starting to spread beyond the prostate, and metastatic, meaning it's going to other parts of the body. For localized disease, which is by far the most common, we can subdivide men further into what's known as low, intermediate, or high risk, based on a whole host of things, that PSA blood test, the finger exam, and the biopsies. And then depending on this, we can stratify patients to the right treatment. It can be a combination of surveillance, where we just monitor patients and follow them. This is probably 60% of the men I diagnose. If you're a little bit more aggressive cancers, or if people do have urinary issues or something else, we have radiation and surgery as outstanding ways of treating prostate cancer, very high cure rates, and very commonly used to treat prostate cancer. And we do use surgery and radiation in both localized and locally advanced disease. Outcomes tend to be outstanding, and people tend to do very well, especially if they're diagnosed earlier when we can treat it. For metastatic disease, this means cancer has spread to other parts of the body. We can use systemic therapy, meaning drug therapy, to get out and about and to neutralize the tumor, kind of put it into remission. Not curative, but the drugs we have nowadays can be very effective, and men can survive for many years with metastatic disease. But getting the biopsy, getting screened, getting the biopsy, getting the diagnosis, sitting down with an expert who can stratify into these different locations is crucial. And then once that happens, we pick the right treatments. And those depend on how much cancer, how aggressive is the cancer, how about the patient's age and underlying health. Obviously, a 50-year-old has 4 or 5 decades of life expectancy, 4 decades of life expectancy, and might be healthier. Someone in their 80s or 90s has less life expectancy, might have other medical issues. And so we try to, again, individualize the treatment based on issues like that. And then people have different perceptions of cancer. There are those who want it out. They come in to see me for opinions. They want surgery because their perception is it's cancer, take it out of me. There are others who feel that surgery is kind of old-fashioned or barbaric and they don't want it. So all of these things go into consideration. And as I mentioned, we look at the stage, how much cancer, how aggressive, and we try to put someone into those treatment diagnostic categories that I reproduced down there. For localized, as I mentioned earlier, we can do surveillance where we monitor it. That's a good percentage of patients. We can use our surgical platforms. We can use radiation platforms. And then once it's metastasized or it's become systemic, we use drugs that basically decrease the male sex hormone testosterone, decreases the hormones, and in that case tends to mitigate much of the cancer. The whole goal of treatment and what is advanced in the last 30 or 40 years is to try to minimize that invasiveness and the different side effects from treatment. Surgical platform has transitioned from open surgery, which is rarely used, to robotic-assisted laparoscopic. These are different platforms even of the robot. On the far left is the multi-port. On the right side is a single port, one small incision about the size of a marking pen, and I can do the entire operation through that little incision using the device on the right. All of these have the advantage of quicker recovery, less scarring, more specific treatments. And in a little bit of shameless propaganda, we are the only hospital, UMass is the only hospital in New England to have that single port. We were in the Telegram about 3 or 4 months ago when we did my first case. I've since done about 40 using the single port machine, but it's something that's very unique to our community, and it's something we really have that we can treat men with, which they don't even have in Boston, which is always considered the Mecca. For radiation, there are 2 different approaches. Well, one can have what's known as external beam. This is the picture on the left. You lay on a table, 15-minute treatment. The radiation targets the prostate and destroys it. Depending on how aggressive the cancer is, it might be 21 treatments, it might be 42 treatments. The radiation oncologists have tried to minimize the amount of radiation given, or to optimize how it's given, I should say, and very, very effective, and equally as effective as surgery. On the right side is something known as brachytherapy, or seeds. You see these little tiny little gold seeds here next to the penny, and those are inserted into the prostate. They're radioactive. They work for 3 months and then kind of burn out, and it effectively kills the prostate just as effectively as surgery or external beam. And they're both excellent treatments, and they're equal to each other. They're equal to surgery, and most academic institutions like UMass would offer that to any man who comes in. We can offer all of these. Once the cancer has spread, you start to need drugs. On the left are a whole series of different drugs that impact hormones like testosterone. The goal is to block the testosterone, which then blocks the prostate cancer growth. This goes back to work from the 1940s. Huggins got the Nobel for this. Back then it was removing the prostate, castration, but now we can do it chemically. And if that doesn't work, we have a whole host of other drugs that are available. The checkpoint inhibitors on the bottom right are the newest, but there are every month it seems like a different class of drug that's showing success in prostate cancer for metastatic disease is being brought to the clinics, and it's really fascinating how many different types of treatments and how to give them and what sequence. But even men with metastatic disease can live 5-10 years on treatment, but the treatments obviously have their side effects. So again, earlier diagnosed, earlier chance for cure, earlier chance to have a more normal lifestyle. Just my last 2 or 3 slides on the important take home. Prostate cancer is very curable, very treatable. Early diagnosis is the key to this. Getting to it before there are symptoms, getting to it when it's still localized and not very aggressive helps that curable and treatable. We want to personalize our treatments, individualize those treatments, and I highly recommend receiving the guidance and treatment at academic centers like ours. This is my department. Obviously, during the age of COVID, we're all wearing masks. And I tried to keep this as brief as possible so I wouldn't run too far over. But this is how we see prostate cancer. This is all what we do every day to improve the health of our communities. And I guess there's some time for questions afterwards, but thanks as always, Lola, for letting me speak.
Thank you, Dr. Sokolov. And my bad, I was so anxious into getting you on because of the time. I'm like, Dr. Sokolov, it's your turn. But I know that we started working together since 2019, and we have been working together since then. And I really do appreciate it. And I know you're also a partner to AdMeTech. AdMeTech family. So I just wanted people to know that this is not just today. It's been a long time relationship. So thank you so much. As always, we appreciate you coming on. So we are going to go into question and answer.
So I believe, Lola, I think I gave the very first talk for Chan, if I'm not mistaken. It was still a little snowy outside. It was in downtown, but I remember giving it. It was wonderful.
Yeah.
Thank you. And we'll always remember that and cherish those moments, So thank you so much. Dr. Stern is going to be doing the Q&A, and of course you're here, and Dr. Castillo is still here. So I'm going to encourage everyone that have questions to put it in the chat. But before today, we got a couple of questions. So I'm going to go straight to, Dr. Stern, are you still on?
Yes, I am.
Okay. And Dr. Stern is actually the president of AdMeTech, and we are in partnership with AdMeTech, which is why we have all these prostate cancer awareness events off and on, in the community, because AdMeTech focuses completely on prostate cancer, new invention, new technology, and anything prostate health. So that's why we're here today. So, Dr. Stern, we're going to go to you, and you or Dr. Sokolov can answer this question. The first question, somebody wanted to know at what age going for like a regular annual visit can someone start asking or raising concern about prostate health?
Sure, I can answer. I'm glad to answer this one. I mentioned it very quickly. So for an average gentleman in the United States, somewhere between the age of 50, 55, should have a PSA blood test, should start with the finger exams, usually annually at first, and then depending on the results, you can start to spread out things. For family history or men of African descent, I would bring that down to 40 to 45. Start the annual screenings with both the exam and the blood test. After several years, if things are low and normal, you can start to spread it out. But I would say 40 to 45 for this community, 50 to 55 for Caucasian.
So, thank you, Dr. Sokolo. So you had mentioned earlier that most of the time when you get to see your patients, especially the people of the community of colors or the African Americans, they're usually at a point where maybe the treatment is needed more. Is there any signs or symptoms that they should be looking for, and, before they get to that point that, it's like at a worse state?
So early on, there really aren't any symptoms. So it's that just being persistent to say, I'm 45, I need to start screening, I need to make sure I'm checking this every year. And that's probably the most effective way. If one starts to have urinary symptoms, if one starts to see blood in the urine, blood in the semen, those can all be signs of prostate cancer, but it's a little later on. Dr. Stern said that at the very beginning. That's later on in the disease, and that can be harder to treat. So that's why it's so important to realize that no symptoms. Get to your primary doctor, get the blood test, get the exams, and just start a routine of doing that, so that if there's a change, it can be picked up very early.
I would like to add, Lova, that if an African American man reaches the age of 40 and comes to a physical exam and his physician does not offer him PSA blood test, I would strongly suggest for the men 40 and older to ask for, at least for men between ages of 40 and 75, to ask for PSA testing of their doctor.
Yep.
And actually, to be clear with the doctor, they understand. We understand that I understand that I'm at high risk because I have African heritage, and I want to make sure I don't have this disease. So I would like to ask for screening with PSA blood test.
I agree.
So that would be for somebody who's aware of what's going on, or who's aware of prostate cancer in the screening. What if someone came to the physician office and don't know what to ask for? How can that be addressed?
Well, that's why it is critically important for us to have events like that in order to bring this knowledge to as many men as possible so that they will know to ask for it.
Exactly. I mean, this is what's so important. Why people like Dr. Stern and I are willing to do this every night of the week. It's because getting that information out, getting that education is the only way you're going to make sure that this gets identified and treated early.
And I just had a picnic of the latest data from the National Cancer Institute, which showed considerable decrease, preliminary peak, considerable decrease of mortality, African American mortality in Worcester. And I would like, there is no question on my mind that the efforts you and Lova have put in Worcester County started paying off.
Wow.
I will send you this early data.
Please do, but thank you for that shout out. Thank you.
Yeah,
I know.
thank you for your work.
Thank you so much. I'm just going to move a little bit to Dr. Castillo. And the question is, with the mask mandate, what are some of the expectations with the new mandates?
So with the new mandate, knowing how the numbers have dropped, and you've seen the numbers drop, in particular, one of the ways we follow it is through the sewage waters. And partly because, everybody says home kits now, so we can't really see what the home kits are. So we don't know, except for water, what the numbers are. So because they have dropped dramatically, the mask mandates have come down. And the recommendations is that if you are not vaccinated, the recommendation is to wear a mask. If you have any type of immune suppression, whether you have cancer, whether you have any immunological disease, HIV, for example, or others. You know, thinking things like lupus, rheumatoid arthritis, and you're taking medications that suppress your immune system. Those are reasons to continue wearing the mask, just for your comfort, or to be around people who are, if you're around people who are vaccinated and boosted, then you can take off your mask more safely. And but right now, when we see those numbers lower, those who are vaccinated and certainly do not have medical issues and immune suppression, that they don't have to wear the mask. There is still always a concern because, again, you saw the numbers for young kids who have not been vaccinated. We don't have those high numbers, but people need to be aware that that's still there and be able to continue wearing their mask. I think that, you know, we always have to be alert that there may be another virus, that we are, it looks like the numbers are down, but that may not be the same down the line. And so we'll keep track of that and be able to inform people right away when there's another virus in the vicinity. But the goal is to continue to understand that we need to continue to mask and we need to continue to vaccinate. We have more treatment now. We have medications. We have, and actually, you probably heard now that if you're positive, you can go to the drugstore and one of the tests at the same time, they will give you an antiviral at the same time to take at the same time. So we're trying to figure out ways of how to treat people who become positive, and hopefully that they won't end up in the hospital. So I think that those are that's where we are right now. Masks are down except in hospitals. If you're taking the train somewhere, any type of transportation, certainly they've come down in the school system in the sense that from the CDC that have said that, you know, the buses, transportation in the school systems, masks are down, and certainly in the school systems. In Worcester, we have not yet. The Board of Health is meeting March 7th to decide what's going to happen in the schools. And that brings that whole issue of again, the low vaccinations in youth. And, you know, we just finished having winter break and people were in contact with one another. And so we want to see if those, if there has been any rise since that time, since they returned to school.
Thank you, Dr. Castillo. I see somebody here was raised. Is it David? If you can just unmute yourself and ask your question. I'm not sure who the question is going to go to. If you can hear me, David.
Yes, I can hear you. And the question is going to Dr. Sokolov. Dr. Sokolov, I came across a publication on the JAMA network. This was published in December last year by Dr. Kishan. And in this article, he talks about the comparison of Black men and white men when it comes to definitive treatments, that Black men actually recover much faster than white men. So my question is, have you noticed the same in the Western community, or have you looked at it at all? I know it's a recent study, but I think that again was kind of encouraging to see that there's good response when in the Black men.
Mitch?
Can't hear you.
Sorry, I keep forgetting about that. We have the dogs and they can bark sometimes. I did not read that actual study. I would say that as long as, you know, our surrounding community, our anchor mission group, our community is getting treated by the experts, I would say the long-term results have been excellent, as good as any other population. The risk would be if someone comes to us a little later, obviously a little bit more aggressive disease. All of those are things that could portend a recurrence. But if we can get them in, we have excellent treatments. We're very skilled at this. I would say that the outcomes in terms of recurrence and everything else are equally as outstanding for both Black and non-Black communities here, at least the ones that I treat. But that's anecdotal. I don't have actual data, but I'm just thinking out loud, letting the wheels in my brain turn. I think so.
Actually, I would like to add to what Dr. Sokolov said, because we have data from military medicine and from veteran administration health systems that have equal access to care. And with equal access to care, they have exactly the same outcomes, irrespectively of race. And this is a very important point. And there is more. Our health. We have annual global summit on precision diagnosis and treatment of prostate cancer that brings together key opinion leaders in just about every field of prostate cancer care, including Dr. Sokolov. And our health disparity panel, actually experts in prostate cancer disparities, pointed out that actually exactly what you said, David, that Black men respond to even better, tend to respond to even better to treatment compared to white men. But this also assumes accurate diagnosis, because Black men are more likely to have prostate cancer lesions in the front part of the prostate that when undiagnosed with traditional, it requires accurate imaging, such as, for example, MRI, not only MRI, but including MRI. And you cannot reach this, you cannot detect this lesion with traditional tools without imaging. And imaging such as MRI become absolutely critical for Black men. So if in VA system and military medicine, they have access to MRI to diagnose better prostate cancer early in Black men, and then apply advanced treatment. And what I want to point out also, David, is that we have AdMeTech jointly with Dr. Sokolov and other experts established prostate cancer equity program to ensure equal access to high quality care, the best we have in the state, in screening, diagnosis, and treatment. So if anyone wants to consult an expert, if screening is right for you, if you are told you need biopsy and you want to look at non-invasive options before invasive biopsy, if you are recommended treatment and you would like to learn more about your options, please call AdMeTech Foundation, and Lova knows how to reach us. You can go to Lova or you call us directly, 617-523-3535, and let us know that you would like to learn more about prostate cancer equity program. It's not formally launched yet. It will be formally launched on March 31st, but we would like to people know. So please, if you have any questions, any concerns about your prostate health, please let Lova know, call us, so that we can connect you and help you through every step of patient care with experts like Dr. Sokolov and his team.
Thank you, Dr. Stern and Dr. Sokolov and David. I know time is far spent, but you just touched on it a little bit, Dr. Stern, but I was going to ask you to tell us some of the latest development that AdMeTech is putting out, because I know AdMeTech is all inclusive when it comes to prostate cancer. So what are some of the new things we should be watching out for as far as reducing your more to invasive side? Just let us know what are some of the new things that we should be watching out for when it comes to AdMeTech and prostate.
Over the last, thank you so much, Lola. Over the last few years, we have seen absolutely tremendously rapid advances in screening asymptomatic men, and that's what we want. Because as Dr. Sokolov pointed out, early stages of prostate cancer have no symptoms. So it's very important to start getting screened at the age of 40, no later than the age of 45, particularly for Black men. And what we saw development not only screening, let's say screening. The goal of screening is to identify men at higher risk of aggressive prostate cancer. This has transformed considerably over the last several years. When men are identified as having higher risk during screening, then we also have enormous number of very exciting precision diagnostic tools, including blood tests, urine tests, for molecular testing, for genetic testing. If men have family history of prostate cancer, particularly brother or father, it's important to get genetic test, that saliva or blood test, to see if individual men are predisposition to aggressive prostate cancer, so they will be monitored more carefully. When men are diagnosed with prostate cancer, we have very precise genetic tools right now, genetic diagnostics, to figure out what is aggressive, what is not, in addition to imaging. So we no longer do imaging. We no longer support biopsy without imaging, blind biopsy, and blind treatment. So that's why it is critically important for Black men who are so much more likely to die of prostate cancer today, Black including Hispanic men, so much more likely to die of prostate cancer today in Massachusetts and nationally, to actually let us help you. Please join our prostate cancer equity program, and we will help you every step of the way in your journey from determining if you are at risk of prostate cancer to helping you if you have side effects of treatment. Does it answer your, does it help?
It does, yes. And the goal of this meeting is just to make people more aware of some of the resources that are available, to help our families, our uncles, our nephews, our brothers, and our husbands out there. And we are very happy to see that AdMeTech is doing that for us. So thank you so much to you and the AdMeTech team. And Dr. Castillo, thank you to you too for what you're doing in the community. We really appreciate it. Is there any last thing you want to say, like an advice or something now that we're going to start taking off our mask, what we should do to protect ourselves and stuff like that?
I wanted to say, Lobo, thank you so much for inviting me. I really appreciate it. I guess my most important thing that I want to say is please get vaccinated. We are still vaccinating. We continue to vaccinate. That's the best way to protect yourselves. And certainly get the first vaccine, the second vaccine, and certainly the booster. So if you're now 5 months out of your second vaccine, you need your booster shot. Right now, your antibody levels are low if you don't have the booster shot after 5 months of your last dose. And so truly recommend everybody getting the vaccine and to understand that it's safe. We've all gotten it and we're all doing well. And so in order to protect everybody else, to please do that and to get our youth vaccinated. So whatever we can do to get our communities vaccinated, we're there for you. And certainly I'm reachable. You know how to get a hold of me, Lobo, if anybody has any questions or any thoughts. Thank you.
Thank you so much, Dr. Castillo. I know time is fast spent, so our call to action piece right now is just taking charge of your health, and just making sure you're staying healthy, going for your primary care visit, and just maintaining a great health. Make sure you're aware of the environment you find yourself, as COVID is still ongoing, even though we are taking off the mask now. So I'm not going to take any more time. I do have Beth Wangari, who is one of our board members. She's actually just going to jump in if it's possible. Can you hear me, Beth? And just do a quick vote of thanks because we've gone over our time, so we can let you go.
All right. Hi, everyone. I'm going to be very quick. So good evening, everyone. It is my pleasure to deliver a vote of thanks on behalf of CHAN for this awareness campaign. I take this opportunity to thank our audience who joined into the education session. Our speakers, thank you so much, Dr. Castillo, Dr. Sokolov, I know he has left, and Dr. Stan. We do not take it for granted. You know, you're sharing your knowledge in an easy, understandable form to our community members. This is very empowering and allows individuals to be able to actively participate in their health, making informed decisions, which has been shown to increase positive outcomes. It is important to note, and this is for our audience and anyone who is not aware, that our speakers are active in the community on health advocacy, recognizing the effects of social determinants of health and outcomes to increase health equity in our community. That's it from me. I drop the mic. Thank you.
So thank you, everyone. Thank you, Dr. Stern. I mean, it is always a pleasure to work with AdMeTech. Dr. Castillo, you know I will find you.
I know you know.
So I know. So thank you so much to everyone. We appreciate it. And it's time to go.
Thank you.
Bye.